you should have these pieces of information in your brain already. An H&H, you know what that is. You should now know what an MCV and an MCH are. The next fact that I have to put in your brain is what an RDW is. I haven't met you yet, and I hope to meet you before you leave, especially if you're from my home state. I might not know your name, but I think I know a little bit about you already because you're just like I am. If I'm reading a book and I'm reading a sentence and I see a word in the sentence and I don't know what the word means, I do exactly what you do. I skip it. And I read the rest of the sentence and I hope that the rest of the sentence tells me what the word meant. Well, for years, I know that when you've looked at patient CBCs, if you didn't know what an RDW was, you skipped it. Well, you cannot skip it after today because an RDW is going to give you a fabulous piece of information. An RDW tells you about how much the red cells vary in size. Here's how I want you to think about it. I want you to pretend that it's Saturday morning. And you wake up and you're thinking, oh man, I could go for some donuts this morning. Because when you think of RDWs, I want you to think about donuts. And here's why. Let's pretend it's Saturday morning, you're thinking, man, I got to have some donuts today. You jump in your car and you drive down to Mesh's Donuts, Shipley Donuts, Square Donuts, Dunkin' Donuts, Mimi, Dunkin' Donuts. You know, they started in the Northeast. All right, so you're thinking of donuts. When you go into one of those donut places and you buy a dozen glazed donuts, your expectation is not that every donut is exactly the same size. Your expectation when you buy a dozen glazed donuts is that the donuts are pretty close in size. So let's pretend it's Saturday morning. You go in, you buy a dozen glazed donuts. You give the lady your money. You get your box of hot donuts. You with me? Can you feel the heat coming through the cardboard? Like you're smelling these donuts. You go out the door, Dunkin' Donuts, you get in your car, you take the box of donuts, you put it on the passenger seat. You put on your seatbelt. What are you thinking? Man, I got to have one of those donuts. Suppose you open your box of donuts and instead of finding a dozen glazed donuts, which is what you ordered and you paid for, instead of a dozen glazed donuts, you found 11 in a donut hole. Now, what are you going to do? You're going back in like I'm going to go back in. Why are you going to do that? Because your expectation when you ordered and paid for a dozen glazed donuts is that they were all about the same size. But if you get 11 this size, and they throw in one that little, it doesn't meet your expectation. That's an RDW. An RDW says that all red blood cells are not exactly the same size, but they ought to be pretty close. That's true whether you're buying donuts or you're looking at red blood cells. All right? So those red cells ought to be all about the same size, and when they're not, it means something's wrong. And that's when we see an RDW that is greater than 15%. So red cells should not vary by more than 15%. And when they do, something is up. Everybody got RDWs. Donuts and donut holes. That's the way you need to think of it. Here's the rest of the information I have to put in your brain. What's a serum iron level? Because sometimes you're going to order a serum iron level. What's that about? That's how much iron is in circulation in your bloodstream day in and day out. Sometimes you need to know that. Sometimes, though, you need to know how much iron is in storage. How much iron is in storage? What about your reserves? When you need to know the reserves, you order a serum ferritin. A reticulocyte count. What is that? Well, first of all, what's a reticulocyte? A reticulocyte is an immature red blood cell. Let me tell you the story of red blood cells. You know the story? The bone marrow makes red cells called reticulocytes. They're baby red cells. They're immature. It takes them about 3 days to mature. So here's what the bone marrow does. unless you've had leukemia or you've taken care of patients with leukemia, you might take your bone marrow's function every day for granted. 24 hours a day, 7 days a week, your bone marrow is on constant patrol. And if it spots an anemia, your bone marrow says, whoa, she's anemic. Let me send out more red cells to correct it. But you know what it sends out? Immature red cells called reticulocytes. And after about the third day of being released into the bloodstream, these immature red blood cells are completely mature adults that help resolve anemias. So when we count reticulocytes, it lets us know about the bone marrow's ability to make more red blood cells when you need them the most. You got it? That's what a reticulocyte count is. And sometimes you're going to order a retic count, and I have a question for you to show you how that works. What's a peripheral smear? A peripheral smear is this. It's when the lab takes a drop of your patient's blood, they put it on a slide, they put the slide under the microscope, and they look at each of the red blood cells to see how they look. They're looking for size and color. So on your CBC report, if the patient is anemic, the lab is going to put out a peripheral smear report. They're going to say, patient's anemic, microcytic hypochromic red cells. They're going to tell you exactly what those red cells look like. All right? So I want you to know that. That's a peripheral smear. You're going to see that that's invaluable to you in certain instances, like this one. Look, a patient is found to have iron deficiency anemia and a B12 deficiency anemia. Oh, wait a minute. He's got two anemias at the same time? Mm-hmm. Oh, my God. They're not going to do that to us on an exam. No, not on an exam, but in clinical practice, patients walk in all the time with more than one kind of anemia. First of all, what do we call? What's a term that we use to describe two anemias going on in the same patient at the same time? What word is that? What term? It's called a mixed anemia, right? Circle number one. It's called a mixed anemia. Let me show you what that means. It means that the patient's got two different populations of red cells. If you have iron deficiency anemia, you have microcytic hypochromic red cells. If you have a B12 deficiency, you have macrocytic normochromic red cells. And the only way you would know that is if you ordered a peripheral smear. All right? So the value of a peripheral smear is that it helps you identify a patient who might have more than one anemia going on at the same time. I don't think you'll see that on your exam, but my goodness, you got to know that for your clinical practice. All right? So there we go. So what's the take-home point? A peripheral smear is invaluable to you when the patient has more than one anemia going on at the same time. Let's look at the rest of those terms. One of them is a TIBC, and to be honest with you, I save it for last because it's the hardest one to kind of wrap your brain around. Let me show you how you ought to think of a TIBC. I want you to look at the palm of your hand, and I want you to imagine that the palm of your hand is a red blood cell. I want you to imagine that each of your fingers is an iron-binding site on the red blood cell. Let me tell you a secret about iron. Iron hates to swim around and around and around and around in the bloodstream. Iron just wants to sit in a site. So if iron is swimming around the bloodstream and it spots a red blood cell that has an empty iron-binding site, iron sits on that site and it won't get up. So if you don't have iron deficiency anemia, all of the iron-binding sites on your red blood cells are full of iron. If you have iron deficiency anemia, on your red blood cells you have some empty iron-binding sites that could accommodate that could accommodate iron if you had it. So let me show you how my crazy brain thinks of this. I was in the grocery store one day, I was buying eggs, and I bet you I do the exact same thing you do when you buy eggs. Don't you open your dozen eggs and you look and make sure there are none that are broken? Don't you do that? Yeah, so I was buying eggs, I opened the thing and I'm like, bazinga, this is a TIBC. So listen, total iron binding, capacity, the capacity to seat iron if you got it. So look, in this dozen eggs right here on the left, every one of those egg slots has got an egg in it. Our capacity to put another egg in this carton is very what? Low. Why? Because we're rich in eggs. Look at the carton on the right. There's not an egg in there. We're low in eggs, and so our capacity to put eggs in it is very what? High. It's the opposite of what you think. So a total iron binding capacity is elevated when the iron count is low. The term we use to describe that is a reciprocal relationship. You got it? So when the iron count is low, the capacity to bind iron is going to be high. That will help you identify patients who have iron deficiency anemia. And again, I'll show you how that works. But you got to own that concept, and it's a tough one to wrap your brain around. Do you have it? You got it? All right, let's keep going. Well, I threw this one out to you a little bit earlier. I want to make sure you were remembering. What's the average lifespan of a normal red blood cell? About 3 months, 100, 120 days. Do you know what lives about 3 days? A platelet, right? Platelets live about 3 days. So what's the best answer to this question? The average lifespan of a red blood cell? About 3 months. You should now ace these anemias. Are you ready? You have all the background information that you need, and I'm going to show you why what you just learned will be valuable to you as we go through these anemias. The first anemias that we're going to talk about are microcytic anemias. What do the red cells look like? They're little, right? They're small. Which ones are those? Well, the two you got to leave here today knowing about are iron deficiency anemia, because it's so darn common, and thalassemia, because it's pretty common, and I think you'll see it on the exam. There's some less common causes, and maybe you'll know them or maybe you won't. But the common causes you must know before you leave me. Let's talk about IDA, iron deficiency anemia. It means there's not enough iron in circulation. When that happens, what do the red cells look like? They're small and pale. They're microcytic and hypochromic. They are small and pale. If you looked at red cells all day under the microscope, I am pretty darn sure you would spot this right away. But let me show it to you. I want you to look at this slide on the top. If you looked at this and you knew what you were looking at, you'd say, oh yeah, those are normal red blood cells. They're normal in color and normal in size. Look at the slide underneath. I think the first thing you notice is how pale they are. They are low in color, and the word we use is hypochromic. But if you look a little more closely, you know what else you find? The size of these red cells is small compared to these on top that are normal. So the word we would use would be microcytic. So when a patient has an iron deficiency anemia, their red cells are small and pale, or microcytic and hypochromic. So physically, those red cells look differently. All right, is everybody with me? Can you see that there are differences in the way they look and appear? All right. You might be surprised to hear this, but when people have iron deficiency anemia, most of them are completely asymptomatic, because you don't get to be symptomatic with iron deficiency anemia until your H&H hits about 30 and 10. And when it hits 30 and 10, you know what you'll say? Whew, Amelie, I am so tired. In the morning when my alarm clock rings, I have to hit it like 4 times before I can get out of bed. Anybody? Maybe you'll tell me, Amelie, when I squat to pick up my 2-year-old and I come back up, sometimes I get dizzy. You might be iron deficient. Maybe you'll tell me, Amelie, I'm trying to get more activity in my day, so when I'm at work, I always take the stairs. I used to be able to take 2 and 3 sets of stairs, and I wasn't winded at all. Now I get to the first floor, and I'm like, I have to kind of stop and catch my breath. Well, I'm thinking maybe you got cardiac problems, but I also might be thinking you might have an iron deficiency anemia. So I'm looking for symptoms of iron deficiency anemia, and what I'm telling you is they typically do not present until people are about 30 and 10 or less than that. Then they come in and they're symptomatic. Here's what else you need to consider. young and middle adults who have iron deficiency anemia don't present the same way that an older adult might. When an older adult has iron deficiency anemia, and there aren't as many big red cells floating around, listen to what they have. They have a worsening of another disease they've already got. Listen to it again. An older adult who doesn't have enough red blood cells bringing oxygen to their tissues is going to have a worsening of another disease they've already got. An older adult is not going to tell you, oh, Emily, I'm 80 years old, and when my alarm clock goes off, I have to hit it 4 times before I get out of bed. They don't tell you that. You know what they say? They say, my angina is getting worse. Or maybe they say, my dementia is getting worse. No, they don't say that, right? The people who live with them say, his dementia is getting worse. So do you see what I'm talking about? And that theme is common with older adults. When they have anemia, they have a worsening of another disease they've already got. On paper, this is exactly what an iron-deficient patient looks like. And you should be able to guess this right now. H&H is decreased, that's why we say they have anemia. If it's iron deficiency anemia, the amount of iron in circulation and in storage is going to be reduced. The MCV and MCH, size and color are going to be decreased. The RDW, the donuts in the donut holes, you got it? It's going to be greater than 15%. So listen, if you're not iron deficient, you have donuts floating around in your bloodstream. The minute you become iron deficient, the bone marrow spits out donut holes. The difference between the biggest and the littlest is greater than 15%. So the RDW is increased. You got it? And then the last one, your best friend, is the TIBC. Remember, if the iron count is low, the capacity to bind iron is what? Elevated. Exactly. So the TIBC will be increased in a patient with iron deficiency anemia. Classically, this is exactly what they look like. Everybody with me? All right, take a look at this question. A patient's H&H is 10.2 and 30.6%. Do you agree they're anemic? Oh, yeah. Which findings are consistent with iron deficiency anemia? Now, look, they've given you norms. What are you looking for with an MCV with IDA? Less than 80. What are you looking for with an MCH? Less than 26, right? So what's your best answer? I'm thinking number 4. Everybody see it? All right, good. So, let me make sure you know something. When patients develop iron deficiency anemia of recent onset, like less than 3 months, 4 months, they have a bunch of donuts and donut holes in circulation. So the RDW is greater than 15%. How long does a red blood cell live? About 3 months, 100 to 120 days. Suppose you've been iron deficient for a year. All of your red blood cells are going to look like donut holes. How much are they going to vary in size? Not a whole lot. What's the RDW going to be? Less than 15%. Do you see how you might get tricked? Do you see it? So it's important for you to be able to determine or at least keep it in consideration as to how long a patient's been iron deficient. Because if they've recently become iron deficient because a woman's got fibroids and she's having very heavy bleeding, and it just started, her RDW is going to be greater than 15%. But if something's been going on that's produced iron deficiency anemia for 6 months or a year, the RDW is going to look normal. So don't take the bait. You follow me? You see where I'm going with it? All right.